Welcome to this public lecture organized by the Ottawa Network for Borderline Personality Disorder. This lecture is being recorded on March the 6th, 2025. Our topic this evening is GPM, or Good Psychiatric Management, and the role of family-based interventions. My name is Floyd Kelly. I am a volunteer and Family Connections course leader, and I serve as a member of the ONBPD board. The Ottawa Network for BPD is a federally incorporated, registered charity in Canada consisting of volunteers who deliver the Family Connections training program to families and loved ones of individuals with BPD. I'm also delighted to introduce Danielle Langlois, our CIO and fellow Family Connections course leader, as well as the chair of the ONBPD board, Michelle Langlois. During tonight's lecture, all attendees are set to listen only and view only mode. Cameras and microphones are turned off. If you'd like to ask a question, please use the Q&A tool to send your question in writing. We'll take a look at your questions at the end of the webinar and pose them to our speakers. You can choose to remain anonymous by checking the anonymous checkbox before submitting your question. And we'd also ask that you do not include any confidential, private, or identifying information in your question. Materials presented in this webinar should be considered as information only and not advice. Now it's my pleasure to introduce this evening's speakers. Dr. Deanna Mercer is a psychiatrist with a passion for helping people with BPD who has been providing DBT therapy to patients for over 25 years. In addition to her role at the Royal Ottawa Hospital, Dr. Mercer is an assistant professor at the University of Ottawa and a psychiatrist in the CMHA Ottawa DBT program. She's an internationally recognized expert on BPD, having delivered over 250 presentations on the subject in the course of her career. Dr. Heidi King is a psychiatrist at the Civic and Montfort campuses of the Ottawa Hospital and lead psychiatrist for the Montfort's Borderline Personality Disorder program. She also consults with the Operational Trauma and Stress Support Center of the Canadian Forces. Dr. King trained under Dr. Mercer's supervision and has a passion for educating patients, families, and healthcare providers about the treatment of BPD. Tonight, Drs. Mercer and King will introduce us to the concepts of general psychiatric management, an evidence-based approach to treating borderline personality disorder, help us understand BPD, and describe some guidelines for families. Please join me in welcoming Dr. Mercer and Dr. King. And now, Dr. Mercer, over to you.
Okay. Well, thank you. And thanks for that lovely introduction. And I know both Dr. King and I would also like to put in our plug now and at the end for a huge thank you to Michelle and Floyd and Danielle and all the people at ONBPD for all the work that they have done supporting family members of people with borderline and helping improving the lives of people with borderline across the Champlain Lynn. So thank you very much for all this work. I don't know how long you guys have been in operation for, but I'm going to guess it's 20 years or more. And we are very, very grateful to you. Dr. King and I are going to talk today about good psychiatric management of borderline personality disorder, which is really an approach to caring for people with borderline personality disorder. We wanted to share this with you because we think that many of the principles are things that you can expect from people who are caring for loved ones with borderline personality disorder. And also there are a number of good hints that from this work that can be implemented, I think, also by family members. So I will, I'm doing the slides here. So the overview, so we're going to cover just very quickly symptoms of borderline personality disorder, just to make sure folks know what we're talking about. We're going to talk about good psychiatric management, how it was developed, and the essential components. We're going to spend a fair bit of time on interpersonal hypersensitivity as being a core component of borderline personality disorder. And this is what makes GPM. And then finally, we're going to talk about family interventions, which are part of the GPM model. They're not separate or some sort of an add-on. They're actually an integral part of good psychiatric management. And we're going to talk about some recommendations for how families can be supportive of their loved ones with BPD while at the same time making sure that they take care of themselves and don't burn out. So, and one just note to Dr. King, please feel free to jump in whenever you want on my slides. So
thank you, Deanna. I love to interrupt. And so I will probably do so throughout the presentation.
Yeah, you're welcome to. Okay. So borderline personality disorder, just for folks, these are the symptoms from DSM-5, grouped into 4 categories. So folks who struggle with borderline have problems regulating emotions. So they have these intense up and down moods. In particular, DSM notes that they struggle with anger, and that's very intense or anger that gets them into difficulties or expressed anger. But we know that people with borderline don't just struggle with anger, they also struggle with very intense anxiety. They struggle often with huge amounts of shame and also sadness. And emotion dysregulation, so that's one of the core groups of symptoms. Um, the second one I usually like to go down to is impulsive behaviors. So people with borderline have difficulties regulating emotions, and they tend to go to impulsive behaviors to help regulate those emotions. The behaviors can include behaviors like drinking too much alcohol, using drugs, engaging in um, you know, non-satisfying sexual relations, and binging and spending. But also, people with borderline have a very high rate of making suicide attempts. Up to 70% of people will have suicide behaviors, and also a very high rate of engaging in self-harm. And those impulsive behaviors are usually used in order to regulate emotions. Um, adding on the third piece, the interpersonal dysregulation, a lot of the emotion dysregulation and the impulsive behaviors occur in the context of difficulties in relationships. And so people with borderline really struggle with the problems that we all have in relationships, and they become very preoccupied with concerns about being abandoned, and often engage in what we call frantic efforts to avoid abandonment. If they think that the relationship's wobbly, they might be calling the person that they're in the relationship with repeatedly, or making promises to do things that they ought not to really be doing, giving money away, staying in relationships that are not good for them. And in relationships, they also tend to go kind of what my folks tend to call black and white. So the person is either completely wonderful and they're idealizing them, they're up on a pedestal, or devaluing, they're down, they're now the worst person in the whole world. And this kind of goes back and forth and back and forth. Um, Also, if we go down into the left-hand corner, people with borderline struggle with struggle with emptiness, and about 50% of people with borderline will report feeling emptiness. So not everybody with borderline has this symptom. However, if you have the emptiness symptom, then it's more likely that you have borderline personality disorder. So if somebody struggles with depression and reports emptiness, it's worthwhile to start looking to see, do they struggle with borderline? And the emptiness is a bit hard to define. Usually when people have it, they just say, yep, struggle with emptiness. But if I was going to try and define it a bit more, it's often linked with loneliness. It's linked with not feeling that they're connected to anybody or connected to life, that they're kind of going through life sort of mechanically without a lot of vigor or interest, and also have a lot of difficulties with identifying the emotions that they're feeling, even the thoughts that they're having. And the other thing that folks struggle with is what we call an unstable sense of self. So this is where people aren't quite sure what their opinions are, who they like to be with, what activities they like. And we think that's partly dependent on the up and down moods, because in one day you're in an okay mood and you really love art class, and then a couple of days later things are not going well in your relationship with your partner and you don't want to ever go to art class again. So it's hard to know, am I a person who likes art or doesn't like art because of these really up and down emotions? And then finally, under stress, people will experience dissociation, so not feeling real themselves, or maybe the world around us doesn't feel real. And most people with borderline, not all, but most, are always somewhat socially anxious, worried about being judged by others. But under stress, they can experience paranoid thinking, worries that people might want to hurt them or harm them in some way. And So these are the DSM-5 symptoms, and you need 5 of 9 to get a diagnosis of borderline personality disorder. The most common way we assess this in clinically is to print out something called the McLean screen, and do that collaboratively with the person that who's interested to find out if they've got borderline. And that's something that's recommended in GPM, is to make this diagnosis collaboratively so that it's you and the person sitting next to each other going, what do you think about this criteria? And the McLean screen, we should have actually put that up for this. We'd do that next time. But the McLean screen has all of these symptoms written out in easily understood language, and you can make that diagnosis together with the person who you're seeing. Okay. The next thing is, as folks who are familiar with ONBPD know, ONBPD and the Family Connections program borrows a lot from dialectical, or sometimes I like to call it diabolical behavior therapy, developed by Marsha Linehan. And the question is, are we putting GPM up today as an alternative to dialectical behavior therapy? We are not doing that because GPM is very complementary to DBT, and these are a set of principles that I think often think of as kind of fill in a lot of the holes that DBT doesn't fill. The two people on the screen here are Marsha Linehan on the left and John Gunderson on the right. I guess so on my right, Marsha Linehan, on my left, John Gunderson. And the two of them probably didn't get along as well as it looks like in this picture, but certainly their therapies work well together. So good psychiatric management is a result of more than 30 years of research and clinical work by John Gunderson and his team at McLean Hospital. John's now passed away, sadly, but he left a lot of work and knowledge from that work. And Lois Choi-Kane, who's now taken over from John, is head of the Gunderson Institute at McLean Hospital, is carrying on in John's legacy. As I've already, and GPM, interesting, John Gunderson and Marsha Linehan started developing their treatments at around the same time. And so GPM shares a lot of the features of DBT. So we do in GPM, we work to validate people and help them understand the things that they're going through, help them to label emotions, help them to identify thoughts. And we also work on setting goals for building a life worth living. And like DBT, in GPM, we address suicide and self-harm behaviors. There were some therapies early on that didn't do this, didn't actually, when somebody had a suicide or self-harm behavior, suicide attempt or self-harm behavior, did not actually go in and say, okay, whoa, hang on a sec here, let's stop and take a look at how do we understand what happened here. And in GPM, along with DBT, were the two therapies that first started to do this, and to require that this be done routinely when somebody had an episode of especially suicidality. The unique features of GPM are this focus on interpersonal hypersensitivity, which we're going to explain a bit more. We talk more about genetics in GPM. We're going to give you we'll tell you a bit more about the genetics of borderline personality disorder. It does talk about the role of medications, and the role of medications in GPM is different than what you might find in Marsha Linehan's book. And the role of family in treatment is spelled out much better in GPM. GPM, you can't, well, at least in Ontario, you wouldn't go into Google and try and find somebody who is a GPM therapist, because this, again, is a treatment approach that gets used in the emergency rooms, inpatient units, outpatients, even family physicians, nurse practitioners. This is an approach that all clinicians can use, and social workers actually also. So the distinct features of GPM start with diagnostic disclosure, sitting down with people, not telling people, but sitting down with people and collaboratively making that diagnosis of borderline personality disorder, checking it out with the person that you're doing this with to say, this is what I've heard. Sounds like this. What do you think? We It includes interpersonal hypersensitivity, and the interpersonal hypersensitivity of folks with borderline is what explains the emotional shifts and the behaviors that we see. We do a fair bit on psychoeducation, talking about the genetics in the course, which we'll do in a moment, but also talking about this idea that when folks have borderline personality disorder, they're interpersonally handicapped, at least when the borderline is at its worst. It's not Those social handicaps do not persist forever and improve as borderline personality disorder improves. But certainly when borderline is at its worst, social functioning and work functioning is significantly reduced. We use a case management approach in GPM, which just means that we're not necessarily, the whole of the treatment isn't focused on what's happening between the person with BPD and the therapist. There is a focus on what's happening inside of the treatment, but most of our focus is looking at what's happening in the person's life outside of the treatment. If they are improving out in their life outside of the treatment, that is the indicator that GPM is working and that we should be continuing. Progress in seeing improvement in your person determines the duration of the treatment and the intensity. So in GPM, we're always looking at, is this person actually improving with our treatment? Partly because we do expect improvement even without treatment. And so the contingency is, if you're improving in this treatment, you continue in the treatment. With regards to intensity of treatment, certainly if somebody's not doing well, we do talk about higher levels of intensity of treatment, but the intensity of the treatment can be tapered off as folks are doing better and maybe do not need to see the person as much, and then increased again when somebody is struggling. And we use psychodynamic principles, which is sort of where you're trying to help people recognize why they're doing what they're doing and recognize previously unrecognized feelings. It's also behavioral. So people are accountable for working with the therapist on setting goals, on getting out in the world and trying things and bringing that information back, showing up for appointments. And the contingencies are what I just talked about, that if this therapy is helping you, then we will continue it. Heidi, did you want to add anything to this? No? Okay. Okay.
Sorry. Yeah. So go ahead, Deanna.
No, so we were going to, the next slide is just showing you how we make the diagnosis, or how we present the diagnosis to somebody who, we've already sat down, gone together through the criteria, and then we would talk to them about borderline personality disorder. And Dr. King has a lovely script, so she's going to present that one now.
So there are many ways, as Dr. Mercer was saying, to diagnose BPD. What GPM focuses on is making the diagnosis collaboratively. So going through the criterion together, sometimes asking the patient to give us examples, right? So we're sure that maybe, say, for example, impulsivity is to regulate emotions, and that's maybe not impulsivity related to another disorder, like bipolar disorder or ADHD, in which both share those types of features. And what we want to do, I think the idea is to give people a narrative and an understanding, right, of how they came to have this diagnosis, how they came to experience the symptoms they're experiencing. And really trying to do this in a non-judgmental way. That's not judging the patient, it's not judging families, it's not judging their previous treaters necessarily, but kind of modeling that flexibility that we're hoping people can develop, which makes life a little bit easier, right, when we can be more flexible. So this script was originally developed based on me seeing someone in an emergency room context. And so I'm going to give them a different name. I'm going to say, let's say, John. So this would be a script that I would use in an outpatient appointment, maybe when I'm first meeting John, and to explain a little bit of how we came to this moment, right, with regards to their illness. So I'm going to read this out. So, John, based on the information you've told me today about your recent experiences, as well as your past symptoms, I believe you might be suffering from a condition called borderline personality disorder. Let me tell you about this condition, and you can let me know if it makes sense to you and your experience. Certain people are born with a biological tendency to feel bigger emotions. What I mean by that is the range of emotions that they feel might be broader than what people experience in the general population. They may feel positive emotions more strongly, such as love and pride, and they may feel negative emotions more strongly, such as rejection and fear. In addition to their emotions, the emotions tend to be quite dependent on what is going on around them in the environment, and especially in interpersonal relationships. With a bigger range of emotions from a very young age, and parents who may have not had the skills to teach them how to regulate them, often people will go on to experience highs and lows in their emotions until they are able to learn skills to manage them effectively. Patients with borderline personality disorder, often because of their genetics, and perhaps because of some experiences in early childhood, are quite sensitive to rejection by their caregivers and loved ones. They may change their behaviors to avoid being rejected, and perceived rejection can activate their 911 response and lead to suicidal thoughts and acts. I think this likely played a role in why you ended up in the emergency room, John, with suicidal thoughts. This sensitivity to rejection can make interpersonal relationships quite difficult and tumultuous for both the patient and also for those around them. Can also lead to feelings of depression and anxiety from an early age. Patients with borderline personality disorder are more likely to develop anxiety disorders and depression, but if we only focus on treating those with traditional antidepressants and therapies, and not the interpersonal hypersensitivity associated with borderline personality disorder, the anxiety and depression tend to be more resistant to treatment. And then usually at that point, coming out of the script, I would pause for the patient's experience and for exploration of examples of the symptoms we've talked about. Following that is a little spiel, which I'll continue on, is the good news is that there are treatments that can help you. There are no magic pills to cure borderline personality disorder. However, there are some good talk therapies where you can learn skills to better manage your broader range of emotions, and sometimes medications that may ease some of the symptoms you experience. If you read about personality disorder, sometimes you will come across the false idea that these illnesses do not get better. Certainly in the case of borderline personality disorder, studies have shown that 10 years after diagnosis, between 80 to 90% of people will no longer meet the full criteria for diagnosis. Impulsivity and the tendency towards suicidal thoughts and acts does improve over time. However, problems managing big emotions and navigating relationships tend to continue. Some of the treatments we will talk about today, however, look at addressing these so you're best equipped to manage your emotions and move forward with your goals.
I think everybody who has borderline needs to hear Dr. King's script, because I think it would make it a lot easier for folks to feel okay about themselves and engage in their treatment. Thank you, Heidi. Okay, so as Dr. King mentioned in her script, once we give the diagnosis, we also talk about, sorry, I'm wrong slide. When we give the diagnosis, at one point in time, there was a lot of hesitancy to make the diagnosis of borderline personality disorder. So one paper was written that said wisdom is never calling somebody borderline. One of the things that we know from, this is a very small study, but lots and lots of clinical experience, is that when we make that diagnosis collaboratively and the person is in agreement with, yes, these are my symptoms, often receiving that diagnosis, people feel better. They certainly don't feel more shame than they did about their symptoms once they have the diagnosis. They don't feel any less likable. And they have a lot of hope because once you know what you're dealing with, it becomes more possible to treat it. And so overall, when people receive this diagnosis, not everybody, but a large majority of people feel better with that diagnosis of borderline personality disorder.
Maybe I'll jump in here,
Yeah.
Deanna. I can say, I mean, over the years now, I've diagnosed a few people for sure with borderline personality disorder. I can count on one hand, I think probably the times where it didn't go so well, right? And I think that, there's a lot to do with an approach. I think borderline PD has obviously been stigmatized a lot by medical professionals. And when I'm talking to patients about the diagnosis or non-diagnosis of BPD, because about 20 years ago, of course, not as many people were being told their diagnosis. I liken it to diabetes, right? And I say it's really important that you know that this is your condition, because if you had a diagnosis like diabetes, how would we ever expect someone to manage diabetes without knowing they have it, right? And when I'm teaching medical students and residents, I try to liken it to that, to really that not telling people diagnosis is really putting them at a big disadvantage to be able to take ownership and move forward with treatments.
Yeah, I totally agree on that. And especially now that we have, 20 or 30 years ago, we didn't actually think that borderline was a treatable illness. I think now that we know that we have treatments and treatments are helpful and they make a big difference, and we also know that people improve over time, I think it's a much more hopeful diagnosis to give to folks. And I think the other piece is that if you make that diagnosis collaboratively, kind of going through the criteria with the person and saying, hey, do you think you have this, this, and this? Usually by the end of that, if the person doesn't have those symptoms, and you're not usually making that diagnosis, right? So I think that making the diagnosis collaboratively also and running through the symptoms together helps us be more accurate, I think, in our diagnoses and get that diagnosis right more of the time.
And I think, Deanna, equally like we do diagnose people, we also at times undiagnose people.
Right. Yes, we do
Um,
undiagnosed people. Yes,
yeah, and
that's just as important as well as helping people understand that, when that this illness will go into remission in the large majority of people, and when your illness is in remission, you no longer have borderline personality disorder, right? And
yes,
so, yes,
absolutely.
we need to get better with taking those diagnoses off of the hospital problem list, though.
We do.
Okay, interpersonal hypersensitivity at the core of borderline personality disorder. So I've already talked about this idea that the affective instability or the emotion dysregulation and impulsivity in borderline personality disorder occurs in the context of relationship difficulties. And relationship difficulties are things like conflict, uncertainty or ambiguity about where the relationship's at, ending of relationships, and loneliness is a relationship problem, because it's the absence of relationships. And it's that affect it's the interpersonal difficulties that get the emotions going up and down in borderline personality disorder. When the relationships are wobbly, the person with borderline usually feel, we'll walk you through another diagram that explains this even better, but that's where the emotional instability comes, and that's where the impulsive behaviors that are intended to relieve that emotional distress or show up. What we do know about this, though, is that the genetics behind borderline is about 55%. So if we were going to say, this is actually all personality disorders are about 50% genetics and 50% environment. If it's true that if you go through a particularly if you've had a very difficult childhood with a lot of abuse, you do not need as much genetics to develop borderline. But for the average person going through, a family that's not highly abusive, a family that's maybe got its own struggles or is really not quite certain what to do with this child who's has this emotional vulnerability, you need more genetics in order to develop borderline personality disorder in the order of about 55%. And this is higher than what we need to get depression, but lower than the genetics that we see for schizophrenia. And the behaviors that interpersonal events trigger include self-injury, dissociation, suicide, suicide behaviors, anger, devaluing others, and also the fears of abandonment and those desperate attempts to avoid abandonment. John Gunderson always liked to remind everybody, though, that genetics is a liability, it's not destiny. So just because, this genetics might run in your family does not mean that your children are definitely going to have borderline personality disorder. And even if you have the genetics, there are families that are well equipped to deal with a child who is a very intense, is an intense child. And I think, what we're learning how to do now is especially for adolescents or young, older children and adolescents who are developing borderline personality disorder, we're getting much better at helping to deal with that early on rather than leaving it into the person's 20s and 30s trying to deal with it. Did you have anything more you wanted to add, Dr. King?
Yeah, I was just going to add that, when we're doing our course, with patients rather, one of the parts, the biological parts that we talk about that I think is interesting for families is that the intensity of the emotions that people with borderline personality disorder experience are biologically different than the rest of the population or the general population. So people with BPD will have emotions that they're more sensitive to what's happening, more vulnerable to having emotions as compared to the general population. So it takes less of a stressor per se to get an emotion going, right? And then when the emotion does get going, it tends to go higher or be more intense than what another person would experience in the same situation. So people are more sensitive, right? The emotion is more intense, and then it takes longer biologically for the emotions for people to get back to their baseline. And so what ends up happening is that because people are so impacted on what's happening in interpersonal relationships or in the environment, they end up having a trigger, having an intense reaction, and they're coming back down to their baseline, but whoops, something else happens, right? In their environment that gets an emotion going. And that's how people end up living the kind of roller coasters, right? And so a lot of people come to treatment and they say, I want less intense emotions, right? And one of the things that we have to talk to people about really early on is part of this is your biology, right? And so the intensity of emotions, may not decrease like some of the other symptoms, but what we do with the emotions after they come on really makes a difference as to how long they last. And I'm always impressed, or people are always impressed when I tell them the biological reaction for anger is actually 90 seconds, right? Well, we know anger doesn't last 90 seconds when anger gets triggered. So what we do, with the emotion after it happens is where we have the power to kind of change the course of where we put our energies.
Okay. All right, and so this is mine and Dr. King's favorite diagram ever because this explains what we see in borderline personality disorder. And I'm going to let you explain it, Dr. King.
Okay. This is always different every time I explain it. So there's no script for this one per se. So, as we know, with our loved ones or with our patients with borderline personality disorder is that things can really change on a dime, right? And it's sometimes really hard and we can miss where things change and why they change so quickly. So this diagram kind of helps explain to families, to treaters, and to patients what's happening in the moments where they go from a connected state down to a less connected state. So a connected state for someone with borderline personality disorder is often what we actually experience in the outpatient department. So people are, they may idealize their treater or the people around them in relationships. They may be somewhat dependent still in relationships and rejection sensitive. So that's kind of at the base. And when people are feeling connected, that's often where we do a lot of our therapy work and where people can make real big gains, right? And what happens is that when people are in a connected state, an interpersonal stress can happen. So I can give an example. So say, for example, I have someone in a session with me, right? And we're doing some GPM. And we're working together, and all of a sudden the patient looks at their phone and I could see that something's changed, something's shifted in their affect. And, then usually, because I'm fairly direct, I'll say, wait now, what's happening, right? What's going on? You seem like something's changed, and they look at me and they say, I just got a message from my friend. We're supposed to go out for coffee after this, and they can't go anymore. They're not feeling up for it. So this may act as an interpersonal stress. And people with borderline personality disorder, I kind of refer to it as an interpersonal hypervigilance, right? So they become very attuned to the cues that they may be rejected and try to protect themselves against rejection. So the person with BPD might automatically think they're not going to coffee with me because they don't like me. They don't want to be my friend anymore, which may not be how other people kind of see the situation. So say, for example, at that point, the person, what we call it, level down, right, maybe into a threatened state. So suddenly, people start having more thoughts of self-harm. They can be more angry at themselves or at their friend, be more anxious, devaluative, but they're still help seeking. So my patient, at that point may look at me and, get quite upset, get angry, and, maybe blaming themselves, blaming the friend. Now you can imagine that at that point, my job is to level that person back up, to use maybe gamer references, but to level them back up to a connected state, right? Because that is kind of the state where people are, more regulated, able to learn, able to mentalize, which means know what's happening in someone else and know what's happening inside myself, right? And so I may put in support. We may talk about, okay, what are some reasons why this might happen, right? What are some alternatives other than your friend is going to leave you? So helping the person mentalize. And that may get them back up to a connected state. You can imagine, though, what could happen is I might get a phone call at that point because it's my phone is ringing a lot. And I say, you know what? I need to take this call. I have to head out. I'll be back in 5 minutes. And my 5 minutes can be 5 minutes. It can be 10 minutes. It can be 40 minutes. So I'm not quite sure what timing. But you can imagine that, again, this may be perceived as a rejection, right? Well, Dr. King has something more important going on. I'm having this big emotional reaction and crisis. My friend's trying to leave me and reject me. And Dr. King is just buggered off somewhere, right? And doesn't care what's happening. That may act as another interpersonal stress, and actually the person may move down into aloneness or despair, right? And what happens is when people get down to aloneness or despair, that's actually where the risk for suicide goes up. And so the idea is we're trying to move people back up, level them back up to a connected state. But based on how far people get down the ladder, we may need more and more supports. And so when I actually use this when I'm seeing people in the emergency room, is when people are down in the aloneness or despair phase, often they're help rejecting. So people come to the emergency room, they may be feeling more suicidal, but they don't want to talk to me. right? Or there may be, lying down, covers over themselves, not able to kind of engage in a conversation, problem solving, things that we think might be helpful. And when that happens, we get particularly worried about suicide, and the 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 actual treatment may be hospitalizing people at that point, or putting in a more holding environment, right? And the idea is that with each intervention we give, we're giving more and more support to the person to try to bring them back up to the connected state. So what's really confusing sometimes for patients, for families, and for the residents the residents we teach is, how can someone go from being fine 1 minute and then 5 minutes later are in an alone state and very high risk to harm themselves? But this is how it happens, through these various interpersonal stresses and rejections that the person perceives, okay? And equally, how can someone go from this alone stage and hospitalized to being okay the next day and more connected? It's all of those interventions that happen in hospital, right? Or with families, right? Maybe the person, ends up being hospitalized, and then their family comes to see them, or their boyfriend calls, or their friend calls them and explains, I really couldn't go out to coffee because I have, a really bad stomach, right? And I didn't want to get you sick, right? So as the support, goes up, so does the levels up to connectedness. And so that's why either way, going down or going up can change fairly quickly.
I think the only other thing to add to that is when folks are in that aloneness and despair level, they often appear profoundly depressed, like the worst depression you can imagine. And it's often, when we're working with folks, often in the merge, somebody's had a breakup and they're really struggling, and their family's very worried about them, and they come into merge, they have a chance to talk with us, they have a chance to talk with the nurses, and maybe we encourage them to call their family or to call their friend, and they have a chance to talk to the friend about the problems that's been going on, and they start to feel more supported by that friend, and it's like the depression starts to lift. But folks are often, worried that, if this depression got this badly this quickly, we should be treating it for a longer period of time, and shouldn't there be medications that should treat that type of depression? And we'll talk about medications in a moment, but it's often when people come into the emergency room, whether they're discharged or whether they're admitted, often we don't make any changes in medication at all. The difference is we put in the social supports, or we try to help people access their social supports out there in the world, in order to help them up level and become back up to at least that threatened level where they might be angry and pissed off at the world, but ideally up to that connected level, because those are the two levels where it's much lower risk of somebody around suicide, not so much self-injury, but definitely the risk of suicide is much lower in the threatened and connected levels. Okay. And I put in here a safety plan, and that because I knew we were going to be talking about emergency quite a bit, and I wanted to show folks a little bit about how what we just talked about actually is embedded in a safety plan for folks who struggle with borderline, at least when we're using a GPM model. And it's handwritten the way I would handwrite it with somebody when they're in a merge or in the outpatient department. So if you look at this safety plan and you look at the bottom left-hand corner, and you look at the prompting events that this person and I put together, was that, they are most likely to experience suicidal ideation when they have a fight with their boyfriend or their mom, if they spend too much time alone, if they're intoxicated, or if they're experiencing flashbacks. And what we really want to be able to do is help that person to be able, when they have those prompting events, to be able to get up to the top right-hand corner, which is their supports, the people they can talk to. And this treatment is really about helping folks develop a supportive social network so that that person with borderline, just like everybody else, when they have a fight with their partner, they have somebody that they can talk to about it. If they've been spending too much time alone, they have somebody that they can talk to about this. Doesn't mean that those people are going to fix that person's problem, but we all do better when we know we've got supports, and we all manage our conflict important relationships and manage loneliness and boredom, manage, things like flashbacks much better when we know we've got those social supports. The other thing that's in this safety plan is warning signs. So we want folks to become very aware of what are the signs that are, the things that are going to happen just before that suicidal ideation starts to show up, so that you can start to that you're getting flagged that this is coming, and I need to start planning for this early on. And again, if you've had a prompting event, the fight with Joe or Mom, and you start to notice I've got the tight chest, my throat's really tight, I know I need to get to those important social supports so I can talk to them. Sometimes, however, we can't get to those important social supports right away. And in that situation, you want to make sure you have some things in place so that you can tolerate distress. And this is where we put in distress tolerance, which comes from DBT, but it's a set of skills that people can use while they're waiting to, while they need to, in the time while they're waiting to get to those important social supports. So it might be the middle of the night, and while your sister's your best support in the whole world, you do not want to be calling your sister at 3 in the morning if she's got a job she has to go to the next day, unless it's an absolute emergency. The other way we use the middle column, the distress tolerance column, is that sometimes we can get in touch with our supports, but we still can't talk because we are so distressed. The intensity of that distress, the emotion dysregulation, is so intense that talking is not really an option. And so we may connect with the people that we're closest to, let them know, hey, I'm having a really tough time, and I'm going to use my distress tolerance plan. And then folks can use the distress tolerance to help them tolerate the distress, and also usually to help take the distress down a bit. Sometimes we can't get a hold of the people that we're closest to. So there's below the people I can talk to is a list of people I can do things with. And these are usually the people in our lives where they are just not good at talking, but they are great to go to a movie with, to play a game of pickleball with, to play, to do a video game with. And just that connectedness of doing something with somebody else can help people with borderline, well, all people actually, but people with borderline also feel supported. I like the fact that John included the people I should not talk to in a crisis. It's really good to flag who you should not be calling up when you've had a fight with your partner. You should probably not be calling up your ex. And all of us have one or two friends where when we try to call them in that kind of distress, they're just not helpful at all. So we make sure we note them. And then below that are the professional supports. Your therapist might have what we call them extended hours, or some availability outside of outside of your appointment. There's the mental health crisis lines, there's the new federal 988 line, and there's always the emergency room. And I always like to point out to folks that this safety plan is also a treatment plan, because in GPM, we're helping you to identify what are the warning signs that tell me, okay, my emotions are now really intense. What are the prompting events that get my really intense emotions going? And where are my important social supports that I can learn how to talk to in a way that's not frightening to them, so that I can have support to go through those difficult things in life that, where all of us, if we have support, do better. And it also includes ways to tolerate distress that we all need when we sometimes can't get connected to those supports right away, or we're too distressed to talk. So it's not just a safety plan, it's actually a treatment plan. Okay. Right. So then so as Dr. King already mentioned, we also talk when we make the diagnosis of borderline, we also talk about prognosis. And this is the best part about well, not the best part, but this is one of the most important things that we've learned in the research over the last 30 to 40 years now. It's not just for borderline, just to let you know, but the improvements in borderline are bigger than what we see in some of the other personality disorders. So that at the time of diagnosis, people to have borderline, you need to have more than 5 criteria. And what we see is that by 10 years out, more than 80% of people have remitted. And when we say what we mean by remitted is people have 2 or less symptoms of borderline. And once you hit that remission, um, you can relapse, but only about a third of people have a relapse in their lifetime, usually in the context of losing an important interpersonal support. Now, the other thing about this, though, is that this is just remission. If people fully recover, and when we talk about recovery, we talk about 2 or less symptoms, plus having at least one stable supportive relationship, and being involved in work or part-time work or school work or taking care of children or taking care of family members close to full time. We call that recovery in borderline personality disorder. And once people hit recovery, they have an even lower chance of it's between about 15% chance of having a relapse lifetime. Now, only about 50% of people get to that recovery by about the 10-year mark. But what we do when we engage people in treatment, what we're really trying to do is two things. One is we're trying to speed the time to remission. So instead of a 10-year course, we're looking at 6 months to 2-year course before we see people at 2 or less symptoms. And we're trying to get more people into recovery. So not just remitted, but fully recovered from borderline personality disorder. And that brings us to in GPM, what are the goals? What are the things that we're trying to help people work on? So in good psychiatric management, just like in DBT, we talk about the cure for borderline personality disorder is getting a life worth living. And in that life worth living, there's really two things. One is having a supportive social network and having a social role. So this working, volunteering, going to school, taking care of children, taking care of family members. And that when as people with borderline work to go towards developing that supportive social network and developing that social role, that's where we see borderline personality disorder start to remit. John Gunderson was famous for talking about work before love. But it's not just work, it's developing a supportive social network and work before you look at trying to get into a romantic relationship. Romantic relationships are wonderful. But if you are looking for a romantic relationship that's going to solve all your problems, it's not going, those relationships are very unstable. So for folks who struggle with borderline, what we say is we need to help you build a supportive social network so that you're not expecting that love relationship is going to meet all of your needs. That puts too much pressure on any relationship to meet all the needs that somebody has. And if you have other friends or acquaintances or things that you do with other people, then if things are wobbly in your relationship, in that close relationship, you're going to be able to get through those difficulties more skillfully. And then similarly with work, work provides us with self-esteem. We go to work, we do our job, we finish it, we feel good about what we accomplished. And again, when we're in a relationship and if things are not going well in our relationship and it's wobbly, if our self-esteem is completely dependent on that love relationship, then your self-esteem completely tanks when things are not going well in that relationship. Having a social role means that you're going to get your self-esteem from other places as well as the relationship, and you're going to be able to weather the storms, the normal storms of relationships much better. And we also work on helping folks make goals, recognizing that this is often a goal in itself, so that people don't have to come into GPM with their goals already laid out. We work on how to set goals, short-term goals and long-term goals. It's a lot like SMART goals that folks are probably familiar with, this idea that they're going to be specific, measurable, and achievable. But we're asking people to make goals in both developing those supportive social relationships and their social role. And the big red box here that John's got, flexibility in establishing goals. Don't be insistent that the patient agree with you. That's for us as therapists. And it's a very, very good reminder as a therapist that you really want to help people set their own goals. As a therapist, often I'm wanting people to make these goals so we can start moving them along, and they're struggling to do this. And then I might want to suggest some goals that I think that they should agree with me on, and that usually doesn't go well. So this might also be a good reminder for parents around, their loved ones with BPD, especially as they're adults, that you want to help them to set the goals. You really want to stay away though from making the goals for your loved one. And then process of change. So this is, you know what, I want to ask something to Michelle and Floyd. I, I think we're running out of time, so I'm just going to jump over this so that Dr. King can present the rest of her slides. Does that sound good? Okay. So do you want to just go to this one, I think, Dr. King?
Sure.
Yeah.
So the other slide that we just skipped over was multimodal treatment. And so I think we recognize in borderline personality disorder that it takes a team and a community sometimes to really help people. And so this includes individual therapy, group therapy, sometimes medications, but also importantly, kind of family interventions, which is, I think, why people are here, for the most part. Go ahead. Okay, so family interventions can take many forms, okay? So most people, I think, when they're thinking, okay, family interventions, people get the idea that, okay, we need to do family therapy, right? And that's actually, if we're looking at the hierarchy, that's actually the 5th on the list. There's a whole host of things that can be done prior to engaging in family therapy. So the first form, which is the first form we also give patients, is psychoeducation about the disorder. So you guys, in actually being involved with ONBPD, being here tonight, you are taking the responsibility and taking the interest to get psychoeducation about the disorder. And this is really the gold standard, would be to offer this to anyone who is interested in learning about it, about their loved one with borderline personality disorder. The next one is actually counseling. There you go. So in counseling, we review the family guidelines, which we're going to go over a little bit here tonight, and people may have questions about. We may give advice, we may problem solve. Sometimes we're doing sessions with people, which is a little bit further down, but we're helping families try to integrate successfully, to help people learn about the symptoms and be able to live more harmoniously with their loved one with borderline personality disorder. The next level is support groups. So that's tonight, we're here at ONBPD. So with the best example of a support group in Ottawa. Helpful if available. We are lucky in Ottawa to have this. This is not the case for all cities. And certainly if they're not available, it's recommended that clinics develop them, because families are a huge part of the treatment and support for people with borderline personality disorder. Beyond that, occasionally we will do conjoint sessions with people, and I have done some of these. They can be useful for planning, problem-solving issues, such as budget, sleep hygiene, emergencies, vacations, right? Especially when therapists are taking vacations. They can be led by family counselor, primary clinician, or both. And basically helpful in sustaining kind of holding environment, right, for the person, and decreases splitting, which is splitting, if we explain it, is it's kind of when someone's trying to get their needs met, they may go towards a person who's going to get those needs met in a certain way. And I think, splitting in a clinical scenario might be if someone has a preference for one therapist, or they know one therapist might meet their needs, whereas another may not. And yeah, I don't know if I'm explaining it properly, but I think splitting is often looked on as a negative thing, but I think it's the person is trying to get their needs met, but there may be differing opinions on how that is reached.
Yeah, and I think it really is I can't get it from this one person, but I'm going to go to this other person and ask for it, and this other person thinks it's a good idea, and now the two people are sort of arguing between themselves. And we call that splitting. I think that also it comes more from our clinical environments, but one of the things John always said about splitting is that it's not the problem of the person with borderline. It's actually the problem of the clinicians, because the treatment for splitting is for the clinicians to talk to each other, right? And to work things out between them, not so much to put this on the person with borderline's shoulders.
And I think splitting happens naturally in some phases of growing up for children. And
Yep.
so certainly splitting can be sometimes cause problems with one parent versus another, right?
Yeah, and I think the exact same recommendations hold for parents, right? If your loved one with borderline is going to one parent to get something and they say no, and then they go to the next parent and the next parent says yes, then the problem isn't to change the person with borderline. The problem is for the parents to start talking to each other and work out how they want to deal with these situations. John used to also say that, usually in families of borderline, families of people with borderline, there's one parent who's is the good parent and one parent who's the bad parent. And so what that means, the thing though, is the person who's the good parent, they actually have to take on most of the difficult conversations with that person with borderline, and let the person who's in the hot seat off the hot seat a bit, right? So, yeah.
And then the last intervention is that of family therapy. I think this is a little bit more common in child, when we're treating children or adolescents. It's very much well reserved for patients and parents who can discuss conflict without having angry outbursts, leaving, interrupting, right? So that it can be quite challenging. Parent blaming can be useful only if the parents can accept with regrets whatever is true in the allegation of the BPD patient. And so that can be really difficult, right, and intense. And so certainly family therapy is not the first intervention we go to, but it can be useful in some cases. So the family guidelines were developed at McLean by John Gunderson and some other people. If I recently reread them and developed some slides for you guys. So this is kind of the short Coles notes of the family guidelines. And a lot of it is you're going to see is very much similar to what we've already discussed here tonight, and how we as clinicians approach it. It can equally be approached similarly by families. So goals go slowly is the first category. So change is difficult to achieve and fraught with fears. So one of the things that can hamper, I think, improvements sometimes in people with borderline personality disorder is that they don't have the confidence necessarily that they can sustain the gains that they make. And with gains comes the fear that if I can do this even once, my family or my clinicians are going to expect me to be able to do it over again and again and again. And maybe if that happens, they won't be there to help me as much, right? And that can sometimes lead to fears of rejection, right? Or not having as much support. So the idea is that, we as clinicians, we as families, we have to lower our expectations, and set realistic goals that are attainable. So in our treatment groups, we talk about SMART goals, and some of you guys would have heard about SMART goals before. But basically, setting ourselves up for success, so that when people are making changes, it's incremental, it's doable, it gives people the feeling that I can do it, a sense of self-confidence, and not setting things up so high that, there's going to be failures, right? So that, and I always joke that the gyms capitalize on this every year by having everyone sign up in January who are going to go 5 times a week to the gym, and then life happens and you don't. And then people by February, March have died off from the gyms. So we're all prone to maybe setting our goals a little bit too high sometimes. And this is equally important for patients with borderline personality disorder.
I think if I was just going to add another example is the school example that we see a lot. So people often will, get into university and maybe are going along and then crash and burn and have to drop out. And then, they patch themselves back up again. And then the next year they try full-time university again,
Yep.
and they crash and burn again. And then on the third time, this is, where we all kind of step in and say, hey, listen, you know what? I know you can do this. You're a bright person. I know you can do university. And we're recommending that you try 1 or 2 courses. Or, what about looking at a less intensive type of program to do, where you can, where you don't have to do 7 or 8 courses. Some university and college courses are 8 courses that you have to do all at the same time, right? And so that's the one that I find often we're trying to help folks with, is to say, listen, let's make these goals a little bit smaller, or sometimes quite a bit smaller, and have you build up to that full-time course load if that I know you can do, but we've got to give it time, and we need to help you get more stable and stronger to be able to do that.
And so moving on to the family environment, we want to keep things cool and calm as much as possible. And I think, probably the ONBPD crew help with how you do that, right? Not easy to do, for sure. Maintaining family routines as much as possible. So when people are in crisis, it's really, I think it's really easy to get caught up in going crisis to crisis, but it's really important to also keep other routines going, because there's more to life than problems, right? And that's sometimes really hard to remember for the patient when they're going through crises. Finding time to talk. So certainly our loved ones will want to talk to us, right? We'll want to have support, but chatting about light or neutral topics and matters are also helpful. So talking about things other than illness, other than crises, is also very helpful, right? And very real in relationships, right? It's very difficult to always be having intense emotional conversations. It's not representative of what happens in real relationships for most people. Managing crisis, pay attention, right? But stay calm. Or maybe I would say, and stay calm, personally.
Thank you.
Don't get defensive in the face of accusations and criticisms. And the biggest reason for this is actually because it just doesn't work, right? If it worked, then I would say do it, but it really doesn't. And we take this advice all the time. As treaters, we take a lot of anger from people. Sometimes when we've made mistakes and then we need to apologize, but sometimes maybe it's misdirected anger. But getting defensive and worked up and trying to rationalize at those points just does not compute. When your loved one's in crisis, the front of their brain, which is responsible for organizing, planning, making good decisions, is not accessible. It's offline. Their emotion brain has hijacked the front of their brain. And so rationale, trying to explain yourself, it really just isn't going to work until the brain calms down a little bit, emotional brain, and the front of the brain comes back online to help out and plan and organize. Okay. So that may be, if people are having heated discussions, it may be having to walk away for a period of time and then coming back to discuss it later. Self-destructive acts or threats require attention. We don't really want to underreact, right? These are serious things. We also don't want to overreact necessarily. And often people's clinical team can kind of help distinguish that for you. We need to listen because people need to have their negative feelings heard. Okay. So mainly it's kind of paying attention, recognizing that what the person's saying is important, listening, and trying not to be defensive. In addressing problems, collaborating and being consistent. So in problem solving, therapists are terrible with this. We want to solve people's problems all the time. And sometimes this really makes people mad because, well, often it makes people really mad because if I'm solving someone's problem for them, inherently, I have really good intentions, but what the message I'm giving, meta messaging, is you don't think I'm capable of solving my own problem. That's what some people will read, right? Also, some people are not looking for you to solve their problems because they're usually, actually, I find our BPD patients tend to be very good problem solvers when they're regulated, right? But what happens is the emotional intensity, the dysregulation gets in the way of them accessing their good frontal lobe, right? And so often people may be looking for us to listen to them, to validate, so that they're able to get more regulated and solve their own problems. So when problem solving, it cannot be done in a time of crisis. Front of the brain isn't working. Involve the family member in identifying the solution, asking whether they can do, right? Is it in their capacity to do what's needed? And do they need help? Okay. All of those will give the message that, I trust that you can solve your problems, right? And I expect that you're going to ask me if you need it. It's putting responsibility, I think, in that way. As we talked about splitting, acting in concert with one another is important, right? So having the same message among family members, the same plan. And if concerned about treatment, addressing it with your family member and the clinician, okay? So not necessarily skipping over your family member and going straight to their doctor or their therapist, right? Talking to them about it, see if they share the concern, seeing if they can bring it to their therapist, but also you can also get involved if you have permission. And then the last set is limit setting. So this is the one I think that a lot of families struggle with. What's a good limit? What's not a good limit? How far do I keep limits? So be direct, be very clear, but careful, right? So set limits by stating the limits of your tolerance, okay? So using clear, simple language is very important, right? Being direct. Do not protect family members from the natural consequences of their actions. So that's a really tough one, I think, for a lot of families, because we want to see our families do the best. We want to see our children not make the same mistakes we might have made, right? Or learn from other people. But sometimes people do learn best from consequences that they have, right? Do not tolerate abusive treatment. Right? Tantrums, threats, hitting. Again, like I said earlier, walk away. And then when the situation is cooled down, trying to return to discuss it. It is once the situation cools down, I would have to say it's really hard sometimes then to go back and discuss it. But it is really important in seeing them what can be done so that this issue doesn't repeat. Because it's really easy at that point, once the situation's cooled down, to just kind of say, okay, that's over. We'll leave it alone. We won't go back to it. But that may perpetuate kind of the issue. And then be cautious about using threats and ultimatums. So threats, ultimatums can make people certainly react, more intensely, but you also have to be clear that if you are going to have a consequence, that you follow that consequence. Otherwise, your family members aren't going to trust that what you say is what you're going to do, which is very, very important, I think, particularly for patients with borderline personality disorder, because they do have the tendency to misread other people's intentions sometimes, and misattribute them to being more negative. So if people aren't saying what they're doing, it's really hard to trust them.
Yeah, and I think if I was going to add this, be cautious about using threats and ultimatums, I'd also add don't give an ultimatum when you're angry or upset. And make sure that before you give an ultimatum, you're willing to follow through with that ultimatum. But if you have set an ultimatum that you can't follow through with, you just have to deal with the consequences of that, the problem is we may end up reinforcing the behavior that we were trying to limit. So, for example, if your ultimatum is if you don't get your homework done, you cannot go out with your friends tonight. And then, so we're trying to get that person to do their homework. But then it turns out that night is a really big deal. It's their best friend's party, that a birthday party that night. And if they miss that, they're going to be completely devastated forever. And as a parent, you're thinking, oh, this was not a good ultimatum for me to set. And we may have to back down from that. It does mean the next time you say, hey, listen, you've got to get your homework done before you go out with your friends, that you're probably going to get a much bigger fuss if that homework's not done when that person goes that night, and you will have to deal with that. But the point, that's what John was talking about when he talked about being cautious, right? Set your ultimatums when you're cool, not when you're angry. Set things that you think that you can follow through with. If you can't follow through with them because you no longer think it's reasonable, you will have to back down, and that's okay too. It just means the next time you go to set that particular limit or ultimatum, it's going to be harder to maintain it. So, yeah. Okay.
Okay, I think that's it.
Actually, this is a good place to just mention, remember what John said was always you knew that you were giving good advice when you, in GPM, if it started off with, somebody asks you a question and you start off your answer with, it depends, right? So I feel like I'm saying, it depends on the situation, what you're going to do. Okay.
Yeah.
And that's the end of our talk. So this is John Gunderson's book, Handbook of Good Psychiatric Management for Borderline Personality Disorder. Some people wanted him to call it Gunderson Psychiatric Management. He said, no, I'm not calling it Gunderson Psychiatric Management. But it's not just for psychiatrists. The people who worked on developing this were not just psychiatrists. They just all happened to come from the McLean program. And headed up by John Gunderson. So that, I think, is it. We have a few other slides if things show up in the questions to help explain those other points, but they are just for questions. So yeah.
Well, thank you so much to both of you. What a compelling presentation with so much useful information for all of us. We do have a few questions that have been posed during the presentation. Michelle, I wondered if you'd be interested in reading the first question.
Sure. So one of the participants this evening, Heidi and Deanna, asked, do people with BPD ever experience psychosis?
Deanna, I'll let you take that one because you're doing you're working with more people with psychosis than I am currently.
So there is it depends question. Okay. So it is not part of the criteria, except for, if people with borderline under a lot of stress, they can get somewhat paranoid about being hurt or harmed by others. And, if there's a significant amount of stress, that could even look a little bit like a brief psychotic episode. But as part of borderline personality disorder itself, it's not part of the criteria. what you do see a lot of in people with borderline is people who have borderline plus PTSD. About 25% of those folks will experience auditory verbal hallucinations. And that is not, you wouldn't make a diagnosis of of a schizophrenia spectrum disorder with that. But those auditory verbal hallucinations are real. They're the exact same sort of phenomena that we see in schizophrenia, and they need to be addressed. They don't respond as well to medications for psychosis as we see in others in schizophrenia spectrum disorders. But they can respond somewhat to antipsychotic medications. They can also improve with some of the CBT interventions that we do to help people with psychosis, so the hearing voices. And there are a number of really good resources online, especially I'm just Eleanor Langdon, L-A-N, is it L-A-N or long, Longden, from the UK. She's a woman who had psychosis and in the context of actually a PTSD, and she's got a very inspiring talk about the voices that she heard and the beliefs that she had and how over time she was able to overcome that. So that's something that I will often show my folks who struggle with auditory verbal hallucinations or voices, and I'll show them that video because they find it inspiring and comforting. And and she's got a couple of other short videos that show her approach to developing compassion for working with your voices. So yeah. The last thing is it's rare actually to see somebody who's diagnosed with borderline go on to have a diagnosis of a psychotic disorder, to see it sort of progress from borderline to a psychotic disorder. It's extremely rare. I think I've only seen that, once or twice where I had somebody who I thought they had borderline personality disorder, but what we were really seeing was the progression to psychosis. What you see a lot more commonly in about 20% of people with borderline is bipolar disorder. And in bipolar disorder, you can see psychosis.
And certainly, Deanna, the only other part I'd add is that people can have schizophrenia and have comorbid borderline personality disorder as well.
Yeah.
And
Yeah,
so
you can
that
have the two of them. Yeah.
you can have both of them together.
Yeah.
As well, if people have substance issues, certainly people can have psychotic phenomenon in intoxication, withdrawal, or as a result of their substances, and have comorbid borderline personality disorder.
Yeah, absolutely.
Danielle, maybe you could read the next question, and also maybe Dr. Mercer, we could stop sharing so we can see each other.
Oh, okay, right. You don't want to see this big thing the whole time. Yes, I will do that. There you go.
Okay. So the next question, if we have a loved one who has not officially been diagnosed with BPD as of yet, but we know they are likely to have it, how can we go about seeking this diagnosis in Ottawa?
So, well, both of us can jump in on that one. I think the best way to do that is depends on how old the loved one is, right? If the loved one is an adult, then you're going to be encouraging them to maybe go and speak with their family doctor. And often nowadays, people will bring in their criteria. They'll have found the McLean screen online, or they've found the DSM criteria, and they'll go to their family doctor and they'll say, "Listen, I've been looking at this. I think this is what's going on." And family doctors are very open to that, reviewing it with the person and helping them access whatever resources. Nurse practitioners also can do that. If somebody has a psychiatrist, then they can suggest it to the psychiatrist. Not, often as psychiatrists, we kind of are looking for we get our sort of sights set on one disorder and maybe forget to actually assess for other things. Like, it's not uncommon for people who have depression to then have borderline personality disorder, but often we're so focused on treating the depression that we forget to assess for the borderline, which is one of the slides that we didn't present was that, but Heidi mentioned that if people have depression that's difficult to treat, it's really worthwhile to get assessed for borderline, because if you do have borderline and we treat the borderline, the depression becomes much more easy to treat. right? So
Okay. Sorry, did you want to say something more,
No,
Dr.
go
King?
ahead. But I think I'd agree with Deanna, starting with the person's family doctor or primary care, and then they can kind of, if they need extra expertise, can refer out as needed.
Okay. Now, Dr. King, I think you touched on this on your last slide, but maybe you could say a bit more. If a loved one behaves in a very disrespectful way, should we allow that behavior to avoid them feeling rejected, or should we let them know that this interaction can't be continued?
Right, yeah. And so I think, it's certainly these interactions can be quite intense and hard to tolerate for people. Once it gets to a point where it's abusive, that people feel, I think, physically threatened in any way or feel that things are escalating, it is not wrong to step away and to say, you know what, we're going to have to pause for now, step away, and it may not even be leaving the room. You may still be in the room with your loved one, but it may be trying to put a pause or a stop on the interaction so that things don't continue to escalate, right? Because we can't really accept abusive behaviors, right? We do the same as clinicians, right? So we try to calmly kind of put a stop in, which is a skill I'm guessing you guys use in ONBPD. It's a skill we teach our
Mhm.
patients, and trying to then, once things are calmer, come back, right, to the scenario. And, that we use it as clinicians. I think you can use it as families. The risk of accepting abusive behavior, of course, is that it may continue, right? And people might get harmed and hurt. And so I think that it is a point where we have to put in a stop and then try to come back later, while still the person is still feeling supported.
Mhm.
I think the only other thing I'd add to that is often saying things like, "Hey, we need a timeout right now,"
Mhm.
but also not abandoning the person, right? We need a timeout. We both need to get cooled down. We can't have this conversation. You're angry. I'm starting to get angrier here. Let's take a timeout and let's connect again in 5 minutes, right? Or 10 minutes. I mean, if it's dangerous, you're going to get yourself out of the situation, but you're going to still keep an eye on the person. But most of the time, it's we both need some time to cool down, and then we're going to come back and talk about this again. And if the behavior was demeaning or threatening, then there's two problems. Whatever got that behavior going and that behavior, and they both have to be dealt with. Hey, we need to talk about how angry you are about me giving you a curfew, right? And we also need to talk a bit about the words that you were saying to me because it doesn't make me feel good, and I'm not okay with that, right? But those are two separate conversations, right? That both have to happen once folks are feeling more settled. Right. And you
Okay.
guys from OMBPD have got your Dear Man Give Fast scripts and you know how to use those. And so you probably do a really good job with opening up those conversations again.
And that's the kind of importance of the coming back afterwards.
Yeah.
That's what's going to help your family member feel reconnected and feel that you're taking what's happened seriously and you're
Yeah.
listening to them.
Yeah, and you're not abandoning the person. Hey, I'm not talking to you when you're like this. I'm leaving. It's like, hey, you know what? We're gonna time out and I'm gonna check in with you again in about 5 minutes to see if you're more settled. And then, it might be 10 minutes, it might be 15 minutes, but you don't want to leave that person feeling like you're taking off forever.
Yeah, and I think, Deanna, some of the things I've said to people, at those times is, I'm really trying to be helpful, but, you know, when things are really loud like this, I cannot think, I cannot concentrate,
Yeah.
right? And I want this sounds really important. Let's take a pause. We're going to come back.
But plus, if you've done the OMBPD program, you also know about distress tolerance, right? And this is a time where probably you're saying, "Hey, I'm going to go grab some ice, and you're going to grab some ice, and we're just going to get this settled. We're going to settle this down, right?" But again, you have to go back to it's not okay when you threaten me, right? Or it's not okay when you use demeaning language. I'm not okay about that. And that's, and you may even have to set consequences. If you do that again, I will not continue a conversation. And if it's something you want from me, then you're going to have to, you may have to even put in a 24-hour rule. If you do this, we can't have this conversation for 24 hours because I'm not okay with being treated like that. Right?
And I noticed the manner with which you said that, which is unlike how most of us feel when we're being sworn at. Um, there are
Right.
several other questions here, but I want to be respectful of everyone's time. So I think we'll bring this to a close. I want to thank you both, Dr. Mercer and Dr. King, for generously sharing your time and your expertise with us this evening, and also for the vital work that you're doing in our community for all of these people that we love and care for. I was Yeah, Dr. King's script was so powerful. I wish we could have read that, to my daughter when we first experienced this. The diagram showing the connection from the connected state to despair is so helpful in understanding that transition that our loved ones go through. And also, thank you for highlighting the value of psychoeducation, which is what ONBPD is all about. I want to thank also our audience for attending this evening. The recording of today's lecture will be posted on the ONBPD website shortly, just in a few days, and that will allow you to share it with others who might find it interesting. And I'd invite everyone to stay tuned for our next public lecture, which will be in April, featuring a panel of individuals who have lived experience with BPD, facilitated by Sean Fisk. With that, this concludes tonight's public lecture. Thank you so much.
Thank you, everybody.
Thank you.